Hello everyone. Welcome back to the series of lectures in endocrinology. So we were discussing about the thyroid gland. We have learned about the anatomy, the development, the physiology, approach to thyroid function tests, hypo and hyperthyroidism. So in today's lecture, we will be talking about thyroiditis. So what is this thyroiditis? Right? So thyroiditis basically comprises of two words, which is thyroid plus itis. So we know that anything in medicine which refers to the term itis means that there is inflammation of the thyroid gland. There is inflammation of the thyroid gland. So thyroiditis can be classified based on the etiology and based on the duration of symptoms. Right? So what are the causes for thyroiditis? It can be classified as acute thyroiditis, subacute thyroiditis and chronic thyroiditis. So it can be classified based on the time of occurrence of the symptoms as acute, subacute and chronic thyroiditis. So acute thyroiditis is generally up to 1 week or 2 weeks. Subacute thyroiditis ranges from about 2 to 4 to 6 weeks. Chronic thyroiditis is that which has been lasting for more than 8 weeks. So this definition is not very clear cut, but this is what it implies. So acute thyroiditis basically has a very acute onset. So let us look at the etiologies. Acute thyroiditis is mainly associated with bacterial infections, especially staphylococci, streptococci and enterobacter. So bacterial infections which can cause inflammation of the thyroid include staphylococci, streptococci, enterobacter. Fungal infections like Aspergillus candida, histoplasma, pneumocystis especially in immunocompromised individuals such as people living with HIV. Then, radiation-induced thyroiditis after iodine-131 treatment can cause acute thyroiditis. Then, sometimes the drug amiodarone can also cause acute thyroiditis. Then, we look at subacute. Subacute means that the inflammatory process has been going on for some time, maybe around 4 to 6 weeks. So, most commonly, viral thyroiditis is the most common cause of subacute thyroiditis. Okay? So, you can see that bacteria is associated with acute thyroiditis, viral is subacute. Then we have silent thyroiditis, including postpartum thyroiditis. Silent thyroiditis means that this thyroiditis is going on silently. They do not have much of symptoms, right? Then you have mycobacterial infections. So tuberculosis causes subacute form of thyroiditis. Then drugs like amiodarone again. Then chronic causes. Chronic is your autoimmune cause. Most commonly we have learned is your Hashimoto's thyroiditis, which is your autoimmune thyroiditis, which finally results in hypothyroidism. Then we have Riedel's thyroiditis and parasites. So parasites cause chronic thyroiditis. Acute is often bacterial when you talk about infections. Subacute is viral or mycobacterial and chronic is parasitic in nature. Alright. So let us look at each of these thyroiditis much more in detail. So acute thyroiditis. So what are the clinical features with which they present? Just now saying that bacterial infections are the cause for acute thyroiditis. So how is it going to present? It is going to present with fever. It is going to present with fever with chills because of the presence of an infection. It is going to present with throat pain. It is going to present with throat pain. Okay. On examination, you can have a tender swelling. You can have a tender swelling where? In the anterior aspect of the neck, below the trachea and between the suprasternal notch. Where do you find the swelling? In the anterior aspect of the neck, beneath the cricoid and between the cricoid and the suprasternal notch, you can find the swelling or the goiterous enlargement of the thyroid gland. Now, if this infection is not curtailed, then it can spread. It can cause spread to the surrounding structures. It can cause parapharyngeal abscess. Okay, so if these complications are present or even because of the pain, it can have dysphagia as well. Okay, so these are the main clinical features of acute thyroiditis. It can cause fever, chills, the patient will feel sick, he will not be able to eat, there will be pain in the anterior aspect of the neck, you may find a tender swelling and you can have complications as well. So when you look at the thyroid function test, when you look at the thyroid function test in acute thyroiditis, most often it will be normal. The ESR and CRP, as there is some infection going on, it will be elevated. How do you diagnose acute thyroiditis? So most often when you do an ultrasound, you will see that there is some inflammation that is going on. You will find enlargement of the thyroid gland. Okay. Sometimes you can even find evidence of abscess, evidence of active infection. If you find evidence of this, then you will have to do an FNA. You do an FNA or you do an aspiration. So once you do an aspiration and you look at it under the microscope, then you can see evidence of neutrophilic inflammation. You can see evidence of neutrophilic inflammation. Alright. And the other advantage of doing an FNA is that whatever aspirate you get, you can send it for culture sensitivity, identify the organism. And the treatment of acute thyroiditis is giving appropriate antibiotics, if this is a bacterial cause for your thyroiditis. But many a times in your immunocompromised patients, we have just learned that viruses or even parasites can cause thyroiditis. So in those cases, you have to be very, very careful about what you are dealing with. Okay, fine. Though parasites can cause chronic in nature, but you should be very careful about the diagnosis in immunocompromised individuals. Alright, so this is about your acute thyroiditis. Alright, let's move on to the next type, which is your subacute thyroiditis. What did we learn are the causes for subacute thyroiditis? We have learned about mycobacterial infections, then we have learned about viral infection. Then there is another form where cause is specifically unknown, but there is a type of subacute thyroiditis which we call as the decuvarian thyroiditis or a granulomatous thyroiditis. Okay. So most often the trigger for a subacute thyroiditis is viral in nature. So most often after an upper respiratory tract infection. They present with what? They present with a mild or a low grade fever. Fever is usually low grade, and they present with a slight swelling in the anterior aspect of the trachea, slight swelling and slight pain. Okay, most often it is slight swelling, slight pain and some fever where the virus or a upper respiratory tract infection has triggered this. In your decuvarian thyroiditis, what is the pathology you will find? So this is, as the name suggests, it's also called as granulomatous thyroiditis. It is also called as granulomatous thyroiditis. So you will find a dense inflammatory infiltrate with multinucleated giant cells. You will find dense inflammatory infiltrate with multinucleated giant cells. Okay. So what do you see on your thyroid function test? What do you see on your thyroid function test? So as you can see in the first few weeks, maybe like up to 6 weeks, what happens? The LT4 is elevated. And your TSH is suppressed, which means that in the initial phase, they undergo a thyrotoxic phase. Okay. So in this thyrotoxic phase, they may or may not be symptomatic for the thyrotoxicosis. Right? So why is that happening? Why is that there is thyrotoxicosis? This is because the virus or whatever inflammatory impulse that we have got, it causes damage of the follicles. It causes damage of the thyroid follicles and it causes release of the thyroglobulin or the stored T3 and T4. So the stored T3 and T4 or the thyroglobulin which is stored within the follicles is released, and that is why there is a thyrotoxic phase. So many a times in this thyrotoxic phase, they may not be symptomatic. Sometimes if they are too symptomatic, they may have palpitations, right? If they may have palpitations, they may have heat intolerance because of this thyrotoxicosis. Followed by which from 6 to 12 weeks, they go into a hypothyroid phase because the ongoing inflammation that is happening, there is no thyroid hormone production, they go into a hypothyroid phase. After 12 weeks, generally, they undergo recovery. Also, you can see that the inflammatory marker ESR is initially elevated, and then as you go forward up at around 12 to 18 weeks, it normalizes, right? So, initially there is a thyrotoxic phase, followed by which you have a hypothyroid phase, and followed by which you will have your recovery. So, eventually your subacute thyroiditis does recover. Okay, so eventually it does recover. Alright, fine. So, what are the clinical features with which they present that we have already looked at? After an upper respiratory tract infection, they may present with a mild fever or a mild swelling over your anterior aspect of the trachea. Okay? And if they are thyrotoxic, initially you may have some symptoms like palpitations, tremors, or heat intolerance. Fine? So how do you diagnose? Your diagnosis is mainly initial thyrotoxic phase, your TSH will be low, T3, T4 will be high. Then they go into hypothyroid phase where the TSH rises and your T3, T4 is low and there is recovery. Okay? So the treatment for this is, it does not require any treatment. So thyrotoxic phase, initially if there is lot of symptoms, you can give them beta blockers mainly for your symptomatic management, but eventually since there is recovery, then you do not have to treat them. Eventually since there is recovery, you do not have to treat your thyroid as such. Okay? But you may have to give them your symptomatic management. So in the thyrotoxic phase, you can give them beta blockers. Fine? And for your pain, what do you want to give? For your pain, you can give them aspirin. You can give them aspirin 600 mg, aspirin 600 mg 4th hourly, or NSAIDs can also be given. In very, very severe cases, we may have to give glucocorticoids and it has to be tapered over 6 to 8 weeks. Okay? So this is about your subacute thyroiditis or your decumbens thyroiditis. Fine? Now let us move on to the next type of thyroiditis, which is called as your Riedel's thyroiditis. So this Riedel's thyroiditis, we have learned that it is a type of chronic thyroiditis. So this is a type of chronic thyroiditis. Okay? It's most commonly seen in middle-aged women. And how does it present? How does it present? This is a great mimicker of malignancy. So, this is a great mimicker of malignancy. It mimics malignancy. It presents as a painless hard goiter and it's often confused to be a malignant or a thyroid neoplasm. Okay, fine. So, what is the most common association of Riedel's thyroiditis? It is associated with an immunological disorder, what we call as your IgG4 disease. Okay. So, initially before IgG4 disease or your IgG4 related diseases were identified, there were different groups of disorders which were presenting similar way, right? So, there used to be something called as your Mikulicz syndrome where there was painless enlargement of the parotid gland. There was conditions such as retroperitoneal fibrosis where there was fibrosis of your retroperitoneum. Then there were disorders like autoimmune pancreatitis, right, where there was again enlargement of your pancreas. What was common in all of this was this term that we call as fibrosis, right? So when they found out that all of these conditions have the same almost underlying process or the almost same underlying process, which is your fibrosis, they were grouped together and they found out that they almost have the same mechanism and they fall under your umbrella term, which is your IgG4 related diseases. And all of these is mainly occurring because the thyroid gland is undergoing fibrosis. So, Riedel's thyroiditis, thyroid gland, in other conditions, the other organs are undergoing fibrosis. Okay, we will be learning about IgG4 related diseases in your rheumatology chapters. Okay. So, what is the treatment? If it is a IgG4 related Riedel's thyroiditis, then steroids is the treatment of choice. Most often, since this is usually confused with a malignancy, often they undergo surgery. And many a time, since this grows in size, it can cause compressive effects. It can cause compression of the trachea, causing stridor, or it can cause compression of the surrounding structures. And hence, if there is compression, you definitely have to do a surgery. And the diagnosis of Riedel's thyroiditis is usually a pathological diagnosis. You take out the thyroid, send it for analysis, and your histopath examination, you get your results. Okay, fine. The next type of thyroiditis is your silent thyroiditis. So, as the name suggests, this thyroiditis is often silent and it is found in the postpartum period. In your postpartum period, there can be some thyroiditis that is happening where you can find thyroid hormone fluctuation, but often not symptomatic, and the management is conservative. Okay, fine. Now we move on to another type of thyroiditis which is called as your amiodarone induced thyroiditis. So in this amiodarone-induced thyroiditis, what happens? Amiodarone is basically a class 3 antiarrhythmic drug. It is a class 3 antiarrhythmic drug. So what is the uniqueness of this drug amiodarone is that it is 39% iodine by weight. Since it has so much of iodine, we know that thyroid also requires a lot of iodine for its functioning. So amiodarone can affect your thyroid hormones when it is taken in excess, okay, or if it is taken chronically. Alright, so because of this heavy amount of iodine in its structure, what are the effects that are seen? It can cause acute transient suppression of the thyroid function. It can inhibit the conversion of T4 to T3. It can cause transient suppression of the thyroid function, and this is because of what? It is because of your Wolff-Chaikoff effect. Wolff-Chaikoff effect means what? Excess amount of iodine consumption diminishes your thyroid functions. It's your Wolff-Chaikoff. Apart from that, in patients with multinodular goiter, this can cause excess thyroid release also by Jod-Basedow phenomenon. So, okay, amiodarone can act both ways. Amiodarone can act both ways, but most commonly it causes a transient suppression in thyroid function. So, when there is a transient suppression, what happens is that there is increased T4, decreased T3, and there is increase in your reverse T3. Okay, right? So, this increase in your reverse T3, this is increase. So, in 15% of the individuals, it causes a chronic form of hypothyroidism which has anti-TPO positive. And in these cases, you will just have to monitor the TSH. You will have to monitor the TSH, look for symptoms and treat with your levothyroxine if it is required. Your L-troxin or your levothyroxine if it is very symptomatic. Okay. Now, there are two types of amiodarone-induced thyroiditis. So, we have your type 1 and type 2. Let us understand the differences between the two. In your type 1 amiodarone-induced thyroiditis, here you have an underlying thyroid abnormality. You have an underlying thyroid abnormality, and most likely, for example, in a multinodular goiter patient, you are giving amiodarone, then what can happen? Amiodarone is indicated for other indications. For arrhythmias, you are giving amiodarone. For atrial fibrillation, you are giving amiodarone, right? So, here you can have a Jod-Basedow phenomenon. Jod-Basedow phenomenon is what? Excessive iodine intake is causing thyroid hyperfunctioning or excessive thyroid hormone release. Okay. So, in these cases, what do? You stop amiodarone. You stop amiodarone. That's very, very, very important. In your type 2 amiodarone-induced thyroiditis, there is no underlying thyroid abnormality. There can be drug-induced lysosomal activation causing destructive thyroiditis, and as a result of which, what happens? The T3, T4 can be released. There can be release of the T3, T4, and it can in fact imitate your hyperthyroidism. So, in your type 1, what happens? In your type 1, there is Jod-Basedow phenomenon and there is hyperthyroidism. In your type 2, there is destruction of the thyroid gland because of your amiodarone, and T3, T4 can be released, and you can have initial phase of thyrotoxic phase. After that, you can have hypothyroidism as well. So, how do you identify your type 1 amiodarone-induced thyroiditis? On the ultrasound, it will show the presence of an increased vascularity. It shows the presence of increased vascularity which is not there in your type 2 amiodarone-induced thyroiditis. Okay. And if you check your antibodies like your anti-TPO antibodies or TRAB antibodies, they can be positive in your type 1. It is not positive in your type 2. Okay. So, type 1 amiodarone-induced thyroiditis, you definitely have to stop the amiodarone. In type 2, the drug can be continued. Okay. And in type 1, you may have to treat with potassium perchlorate or steroids or lithium. You may have to treat with steroids, lithium or potassium perchlorate. Okay. So, this is about your amiodarone-induced thyroiditis. So, with this, we have come to the end of our session on thyroiditis. What all have we learned? We have learned about what is thyroiditis, what are the etiologies. We have learned how do you differentiate acute, subacute, chronic. We have learned the various types under that. We have learned amiodarone-induced thyroiditis as well. Thank you.